Alright, the fourth part of our series on central nervous system medications is going to deal with anti-epileptic medications and general anesthetics. Your objectives for this unit are to be able to identify the medications that are used to treat and prevent seizures, to describe two routes for the administration of general anesthetics, and you should be able to list at least 3 side effects associated with general anesthesia. So the first thing we're going to deal with are medications that are used to prevent seizures, to treat seizures. And in which case we have 2 types. We have anticonvulsants and anti-epileptics. Now, all the primary drugs that we use to treat epilepsy possess anticonvulsant properties. And an anticonvulsant is defined as a drug, usually administered IM or IV, that terminates convulsive seizures, that stops the seizures in their tract. And what they do is they decrease the excitability of the brain cells. Now, the term anti-epileptic, on the other hand, infers that the drug is usually administered orally and can be used prophylactically to reduce or prevent seizures. So we're talking about anti-seizure, anti-epileptic medications. 3 primary ones come to mind. First is that of the barbiturates. I'm not going to spend a whole lot of time on it because we already did in a previous lesson. But all the barbiturates have anticonvulsant properties. Only a few of them, though, such as phenobarbital, have the additional property of being anti-epileptic. The issue with these, as we talked about before, is they are highly addictive. So it is usually not one of our first choice of medications when we are treating a seizure disorder. Specifically not if we want to maintain someone long term. Now the hydantoins are probably our most popular group of medications used to treat seizure disorders. And of this, the most important drug in this class is phenytoin, otherwise known as Dilantin. Phenytoin is a very potent anti-epileptic drug, and it can be used in several types of epilepsy. A significant advantage of it is that it has very, very, very little sedative effects. So it can be administered for life, and someone can drive and operate equipment and be just fine on these medications. It works by affecting the activity of those neuron ion channels, specifically sodium ions, potassium ions, and calcium ions. And so by regulating the ions crossing through the channels, particularly sodium, it is able to inactivate the nerve impulses and therefore decrease the seizure activity. The nice thing about Dilantin is it can be administered, as I said, as anti-epileptic long-term, but in addition, it can also be given intravenously if you have acute situations. It can be used to treat convulsive seizures as they are happening. And we call that case of status epilepticus, when an active seizure is going on. So it's very versatile, very useful medication with very little sedative type of side effects. You do have to watch blood levels to make sure that you're maintaining enough of it in the body so that you are preventing the seizure activity from occurring. Third one on here you see is benzodiazepines. And primarily where we see these used is for status epilepticus, that active seizure going on. in which case the drug of choice currently to arrest a status epilepticus is called Ativan, generic name of lorazepam, and it is administered IV. Um, Valium or diazepam is also effective, but it doesn't last as long, doesn't have as long of a duration of action as Ativan. So sometimes when we give Valium to stop a seizure, um, this it may the seizure may start to reoccur, and we may need to give additional doses of it. So the benzodiazepines, specifically Ativan and Valium, are used primarily in stopping seizures in their tracks. I'm going to switch gears a little bit now and look at general anesthesia. A little bit overview. I'm not sure how much you know on general anesthesia itself. It's a little overview of general anesthesia. There's really 4 stages to it. And the first stage when we want to administer general anesthesia is that of called analgesia. This stage is characterized by a decrease in response to pain and hence analgesia. And it also gets kind of that feeling of euphoria, of well-being, of elation, and then a gradual going to sleep. So that's kind of that first stage that we have in general anesthesia. Now, once that cerebral cortex is fully depressed, the brain will then enter into stage 2 of general anesthesia. And that happens when the hypothalamus really now starts controlling body functions. And it's called the excitement phase because what we see is now the cortex is depressed and the hypothalamus is picking up, and therefore we get an increase in that sympathetic, that fight or flight nervous response. So what you will see in that second stage when someone's going under anesthesia is you will start to see the blood pressure elevate, you will see the heart rate increase, respirations and muscle tone will also increase, again, for a short period of time, while we're in that balance of the hypothalamus being more active than the cerebral cortex. Then what happens is someone passes into stage 3. And this is what we call our stage of surgical anesthesia. And this is where the point where we want to perform surgery. We still have cardiovascular and respiratory functions, but the spinal reflexes are inhibited, so the motor control is not there. Skeletal muscles are now relaxed, and the blood pressure is down, the heart rate is down. So, this is our place where our surgical procedures are being done in stage 3 of general anesthesia. Stage 4 is called medullary paralysis. Basically, paralysis of the medulla oblongata. If this happens, cardiovascular and respiratory centers stop and the person will die. So we really don't want to get to stage 4 of general anesthesia. The ideal is if we're going to be performing a surgical function, we want to kind of operate in that stage 3, knowing that they're going to pass through 1 and 2 before they get to 3, and then as they come out of anesthesia, they'll pass through 2 and 1 before they come out of their anesthesia. So now, general anesthetics are administered by 2 primary routes. We administer them either by inhalation or by intravenous injection. Both of these routes provide a rapid delivery of the drug into the blood, and it facilitates a very smooth progression through those stages of anesthesia. In addition, general anesthetics for the most part are lipid soluble. So they dissolve in the blood and then go into the fats, allowing for a really good distribution through other tissues, through the majority of body tissues. Now, inhalation anesthetics include what we call the volatile liquids and gases. Things such as an example of a volatile liquid would be ether, and an example of the gases would be that of nitrous oxide. Some of you may have had that to assist with dental extractions. All the inhalation anesthetics except for nitrous go through all stages of general anesthesia. Nitrous does not go down to that third stage. So all except for nitrous can be used for both induction, getting someone in, and then maintaining general anesthesia. Nitrous will not get down to that third stage. That's why it's good for things like dental extractions and small minor procedures like that, but it would not be good for doing a major surgery. We cannot maintain someone at a level 3 with nitrous oxide. The injectable anesthetics include barbiturates, ketamine, Versed, Valium, Ativan, and Propofol. And there's a whole list in your book to give you a variety of them. Of those that I mentioned there, Propofol is probably one of the most readily used ones that I see nowadays. It's really accepted well for induction, sedation, and maintenance of general anesthesia. And Propofol also has a short half-life, so people tend to clear it out of the system very quickly, so they don't hold on to those feelings of being anesthetized for a half a day or a day afterwards. They pretty well clear it out of their system pretty quickly. So we see a lot of Propofol being used for procedures these days. So now, what is really the mechanism of action of general anesthetics? All of them are basically central nervous system depressants. But how much depressant they do differs with every drug. Not only do the anesthetics interact with a variety of receptors, the interaction of multiple receptors can synergize or enhance anesthetic effect when drugs are used in combination with them to maintain the anesthesia. So as a result, we'll often see additional medications used along with the general anesthetic to help maintain it and synergize the effects. We don't have to use quite as much of the general anesthetic. Most, as we said, inhibit the CNS, and how they work is by working with those membrane ion channels. So they block ions from crossing over the cell membranes and therefore decrease excitability of the central nervous system. They bind with what we call those GABA receptors, and then they decrease the excitability of the brain cells. So again, if you're looking for the mechanism of action, how it works within the cells is that the general anesthetics bind with the GABA receptors and therefore limit sodium ions, any ions, from crossing over the membranes and therefore decrease cellular excitability in the brain. So now, what's the effect of all this stuff in general anesthesia have on the body? Well, the primary therapeutic action of the anesthetics is for the patient to be in that anesthetic state, in that state whereby they are not feeling and recognizing pain stimulus that's going on in their body. So at low doses in the blood, they can relieve anxiety and just produce a slight sedation. So for minor procedures, such as maybe setting an arm, a broken arm, or doing some superficial suturing, things like that, low levels of these anesthetics work really well for short procedures. If we increase the level, we then can produce what we call anesthesia, whereby the body is no longer aware of any of the sensations coming in. But keep in mind, whenever we go to that point of anesthesia, the medications are influencing a variety of other tissues throughout the body. So when we talk about the side effects of general anesthetics, we need to consider the fact that what's happening is the medications are being distributed throughout the entire body, and therefore they have an influence on a variety of the other tissues in the body. So if I asked you, thinking back on that now, to answer this question, the side effects of general anesthesia include respiratory depression, myocardial depression, vomiting, hepatotoxicity, or all of the above. Hopefully you chose number 5, all of the above, because again it has a general systemic effect. General anesthesia will slow down the breathing. Hopefully you don't get to that stage 4 where it totally depresses it. It will slow down the heart rate. Remember, first you'll have that point in stage 2 where it will increase, but then it will decrease. It wreaks havoc on the GI tract, and anybody who's ever had general anesthesia may recall feeling nauseated and or vomiting after having it. And hepatotoxicity. Hepatotoxicity is toxicity of the liver, and because they are metabolized by the liver and then maybe excreted by the kidneys or by the respiratory system or a variety of different ways, that liver has to filter out all of these medications, and as a result could result in toxicity. Too much of it could be toxic and cause liver damage. And with that, we end section 4 of our lecture on central nervous system medication.